So there is no doubt, of course, that the gold standard for fistulas, for vascular access, is distal radiocephalic fistulas. However, the problem is that you don't usually get this patient. More and more we get these diabetic patients, multi-operated, no veins, no arteries. That's why we have 50 to 60% problems with maturation. And in most places, when this is not possible, we create a brachial inflow fistula, and brachial inflow fistula is a fistula with major issues then, like life-threatening issues, bleeding problems, Still syndrome, aneurysm creation, all these problems. So there is a solution in between that we often forget, let's say the Jennings fistula, with a fistula created between the proximal radial artery and the deep communicating vein. And we basically take advantage of the fact that radial artery proximal is more healthy vessel, larger caliber, larger veins, and the perforator is just next to it, and you don't have to swing it over. It's just an easy fistula to do surgically. And essentially, when you're a vascular access expert, when you want to call yourself a vascular access expert, you want to be able to create the best possible fistula with the least possible interventions, because, you know, with the years you develop with your patients this personal relationship to trust you. And when you're able to do a fistula that's going to be used fast enough, and the patient is not going to get operated over and over again, then you're really feeling successful in completing your mission. We described the results of the surgical fistula, the proximal radial artery fistulas during vascular surgery with Dr. Jennings for 1,400 patients. And now, regarding the percutaneous system, the ellipsis vascular access system is basically creating the same type of fistula with a few differences, but it's basically the same principle, the proximal radial artery inflow to the deep communicating vein. The technique, briefly, you will puncture the median cephalic or median basilic vein here at the level of the elbow. Under ultrasound, you will navigate down the perforator. Through the perforator, you're puncturing the proximal radial artery, and then you will bring the sheath in, the device in an open position that will capture here the artery and here the vein. Then you close the device, you activate the device, and with thermal energy and pressure, it will create a permanent anastomosis that you can see here under ultrasound. After this creation of the anastomosis, we decided to balloon the anastomosis to accelerate maturation with a 5x2 mm balloon in most of the patients. And this is how the anastomosis looks, and this is how the patient arms looks like 4 days after creation. You can appreciate here that essentially this is like he had some labs drawn, so it's really pretty cool, and patients are very happy. This is how it looks under ultrasound. This here is the anastomosis, and of course, given that you have a normal anatomy, you have a cephalic and a basilic vein, so flow goes to both cephalic and basilic vein if you don't like it or anything. And let me speak a bit more about the side branch ligation or not. So these are, of course, two surgical fistulas, radiocephalic fistulas, have been there for a few years, and what you see that the first part of the cephalic vein is kind of getting dilated, it's more pressurized because there's only one vein getting the flow. But after this spot right here, what's happening in these fistulas is that you have the blood draining from 3 systems, the perforator going down the brachial vein, and the cephalic vein and the median basilic vein, and these veins are getting developed, they are usable, they have low pressure, you don't have issues there. And that's basically what we're doing when we're creating these fistulas. We are creating a radial artery fistula draining to 3 different systems. And in Paris, we decided that this is an advantage that we want to keep in order to keep these veins low pressure. Now, about our results, within these 2 years, we operated 216 patients. The technical success was very high, 99%, because you realize after a point that basically is a puncture, when you realize how to do a puncture, it's a really very simple technique. You put a device in and you create the anastomosis. The follow-up is almost 2 years for some patients. We had to do some more interventions, about 36%. And we have some excellent secondary patency of 96%. We didn't have any serious issues with these fistulas. The average flow is 900. We didn't have any high flow fistulas. We didn't have any Still syndrome. We superficialized about 7%, which is 15 patients for this series. The average maturation time was about 4 weeks. And about 10% of the patients, we were able to cannulate them very fast in less than 2 weeks, avoiding catheters, being able to take catheters out when there was a problem. This is how the Kaplan-Meier looks, and you can see actually on the left side our life table analysis, on the right side the one from the paper from Dr. Jennings, And you can appreciate here that they compare pretty well. They're, if not better, at least equivalent. And a couple of things about declots and draining vein stenosis. So, contrary to a surgical fistula, when you get a clot, you will have a clot from the anastomosis up to the level of the fascolateral that will re-establish the flow. When you have a percutaneous fistula, you may have a plug at the level of the anastomosis, but because you have all the tributaries, you maintain flow into the veins, so you don't have clotting the entire fistula, which basically means, and this is what we do, you can just go in, do a sharp recanalization with a needle, balloon it, and you're done. The fistula is running again, and it's ready to be used. The other thing is that because you maintain all these veins open and you have a multiple draining vein system, you're not abusing the vein the way you abuse it with a surgical fistula. Let's say you have 1 liter of flow going there day and night all the time, then the vein starts creating aneurysms, stenosis, you name it. So this is why I believe that we didn't have to balloon any draining vein stenosis in this fistula. So the main thing that we did, if we did something, was to just balloon the anastomosis when we wanted to have some extra flow. This is how a day in clinics looks for us now. You see punctures in the cephalic vein or punctures cephalic and basidic vein, no issue of aneurysm or any other problem. We were also able to create for distal seminofistulas. These are variable locations of distal perforators, and we could do this for 4 of our patients. It's not something that you can do for the majority of patients, but it's something to keep in mind, and I think with the evolution of the technique, we might be able to do more in the future. And about, if we do easy patients or not, what about these patients? You can appreciate here this lady that she had multiple catheters, scars everywhere. What you don't see is that she has a beautiful percutaneous fistula being used for the last year. Or this patient with multiple amputation with contraindication for a surgical fistula, we were able to do a percutaneous fistula, tailor it, customize it to 400 flow, just leave it there, the patient still has dialysis with this fistula. So in conclusion, that's a minimally invasive one-stage AVF creation technique. There is the advantage of you're able to keep it moderate flow, low pressure, having multiple vein outflow seems to be the real advantage, not just being able to do a fistula without a scar. You can do early cannulation of weight catheter in some patients. It's definitely a very safe technique. It's very fast. When you realize how to do a puncture, you can do the case 10-15 minutes. Patients and nephrologists are very happy. And I really think it's the future, so you better get on the bus before it's too late. Thank you very much for your attention, and if you like that stuff, you're all invited to Paris.